Thank you. Buongiorno a tutti. So I have on my right Eman from Kurdistan. She's a fellow. She spent several months with us. She will leave us soon after the Congress, so this will be her last cat study with us in San Donato today. We have Carmelo Arcidiacono on ECHO, Federica, our anesthesiologist, Lina, Giovanna, and Marta. Please, you can give a look at her. Sure. They are very nice, very hardworking, and collaborating with us. So today we have a patient that Eman will introduce you.
Slides.
May we have first slide? Yeah.
Okay, our patient is a 44-year-old female with a history of frequent episodes of migraine with aura. Her transthoracic echo showed the PFO with paradoxical right to left shunt on both basal and after Valsalva maneuver. Her brain MRI on 2006 was normal and started on anti-aggregation therapy. Since then, she developed 3 transient ischemic attacks. Physical examination is normal, and her last brain MRI on 2010 showed multiple ischemic lesion. So the intended procedure is PFO closure.
That's perfect. Thank you, Eman.
Thank you.
So we'd like to look at pictures from TEE made by Carmelo and have his comments.
Yes, please.
Please, Carmelo.
Hi, good morning,
Good morning, Carmelo.
I've got Mohammed here helping me out, Mohammed Hellis. Very precious help. So we started studying our patient, and at first we thought we could see just a very long tunnel with some floppiness of the fossa ovalis, as you see here. But actually, after several attempts, we couldn't cross this tunnel that we just had measured. And we found out that actually the only atrial communication in this patient was a fenestration in the fossa ovalis, as you can see here, with left to right shunt, even in basal condition. And actually we crossed, that's the only thing we could cross with a guide wire. And we measured all the floppy part of the floor of the fossa ovalis, which is about 22 millimeters. Thank you.
Okay, thank you, Carmelo.
Did 3D help you at all or not?
Well, in this case, at first I thought that there was, well, I can show you some 3D pictures, the initial ones. So at first I thought that there was some lift up, some tenting effect of the guide wire. But actually, there is no hole that you can see underneath.
Right.
So 3D wasn't particularly effective in this case, but on 2D you can see very clearly that there is actually only a fenestration across the...
Yeah, that picture is very nice, Carmelo. Yeah. Even in 3D you see the fossa ovalis going down after the guide wire, so we are passing through a fenestration.
So you may have had to change your strategy, knowing the anatomy is different to what you predicted.
Yeah, absolutely, you're right. So this case is quite nice concerning the history. As you can have seen, 2006 brain MRI was normal, then TIS or strokes, and then positive MRI. So we have a quite floppy membrane with a fenestration of around 5 millimeters on TEE. So I would like to ask to all of you which kind of device we will use today.
Right, I'll ask Kevin.
What about sizing it to start with to try and understand it a bit better?
What about sizing?
Balloon size.
Yeah, we balloon size it just for you, in the sense that we usually do not balloon size. May we have the angel of the balloon sizing? We usually rely on the aspect on TE when the stiff guide wire is passing through the PFO or the hole. And here you can see, may you put, larger? Yeah, this is the sizing.
So that's 5 millimeters.
5 millimeters. That's somehow, yeah, as a
So,
PE.
so I guess an 18 millimeter Amplatzer PFO device will do a nice job here.
Okay. All of you agree with that proposal?
I'll ask Gennaro and Francesco whether they think it's different.
I think it's a good case for the multi-fenestrated HD device for me.
So in this case, we should go for 25.
You're suggesting an ASO device?
Yeah, a multi-fenestrated, yeah.
Oh, you mean a cribriform device? Okay, so we've got the suggestion either of a PFO 18 or a cribriform device, and Gennaro?
And I think that is enough, the 18 Amplatzer for PFO. 18, very
Right.
small.
So
I think this is enough 18.
I mean, the 18 cribriform Amplatzer is the same as the 18 PFO, except they charge slightly less for it.
Right. I mean, I suppose that there are different devices that you can use here, but there are some devices which are not going to be suitable. So the Premier and the Coherix are probably not devices that you would use. Is that correct?
Yeah, we agree with you. So we have the three options here in the lab: that Cardia, then the Helix, and then the Amplatzer, either PFO or cribriform device. So
I think they're all very suitable.
Yeah, absolutely. So
let me just ask the audience what they think.
Yeah.
Who would use a Cardia device for this? Hands up, please. There are some who would use a Cardia, but not a large number. Helix. Some there, again, not a large number. Who would use an Amplatz device? The majority would go for an Amplatz device.
So another question: PFO or cribriform?
But they're the same.
Yeah, PFO 18 or cribriform 25, because I mean.
Oh, 2018 or 25. You could use either, I think, but you only got 6 millimeters on your sizing, so why not use the smaller one?
Why not using? What?
You just
smaller
got
one.
6 millimeters
Yeah.
when you did the balloon sizing, so 18 should be enough.
Okay, so the audience voted for 18.
Well, let's just see. Who would go for an 18 millimeter device? Hands up, please. A moderate number. And who would go for a 25? No. I think the majority would go for an 18. And I suppose because the atrial septum is not particularly aneurysmal or floppy, I think an 18 would do very nicely.
Okay.
If it had been extremely floppy, maybe a 25 would stabilize everything for you.
Okay, so that's
But
democracy.
your choice, Gianfranco.
Yeah, that's democracy, so we shall go for an 18.
So you've anticoagulated the patient, yes?
He's asking about anticoagulation.
Yeah. So we prepare quickly the introducer. All of you know the device. While I'm putting in the introducer, Eman will show you the device.
Gianfranco, if there wasn't the history of TIA, would you still close it for migraine? Because we had a discussion this morning, and very, very few people are actually closing PFOs purely for migraine because there is no evidence base for it.
Yeah, I agree with this, the conclusion of this morning. The only exception are some very few patients suffering a lot of migraine where multiple drugs have been used and where other options are not available. So we discussed with the patient, and together with him and the neurologist, we could decide to do this therapy, that is PFO closure, in an ex-adjuvantibus way. So very rare patients. So Eman,
the device has been screwed on, flushed underwater, and placed in the loader.
Yeah. So Eman will close for us the PFO. That's the last cut with us, so it's important to show to everybody.
pre-load them with antiplatelet drugs or not?
Do you preload them?
With clopidogrel and aspirin beforehand or not?
Yeah, we start some days before with aspirin.
Yeah. And then do you continue just with aspirin, or do you add clopidogrel?
Just with aspirin for 6 months. Then we perform a cranial Doppler with echocontrastography at 6 months, and if it is negative, we stop aspirin. If it is positive, we continue aspirin for other months, and we repeat the transcranial Doppler at 12 months. At that point, if there is still a shunt, significant shunt, we perform a transesophageal echo. We also perform it.
In some instances, there is an indication to continue on aspirin indefinitely, particularly with some of the very tiny PFOs where there is no substrate like an aneurysm or a tunnel, because you don't really know the cause of the stroke. So if they're tolerating it, there's no bad reason not to continue with the aspirin. So you've got the sheet across now.
Yeah, the sheet is across. Here you can see the device attached to the system. We pull back a bit, show it again, Eman, just to be sure that everything is okay. So we keep pulling. We are near the...
One good thing that we tend to do is when we do balloon size, we'll see where the waist is in relation to the spine, and that will give you a very good idea as to how far back you can come.
Okay, may we have also echo, small. You see the left lateral disc on the septum, and then we are ready to open also the right lateral disc. Eman will do for us. Okay, you can see here the 2 discs nicely placed. May we have a color Doppler interrogation of the septum? The device looks very nice to me. So I think that we could unscrew and deploy the device. Do you agree?
Exactly, I think so, yes.
Okay. Let's do on...
Is that a little something floating on the left-hand side, or is it just artifact?
No, it's okay, thanks. Do you wish a bubble testing?
I think you should do, and if you can give us some 3D, that would be nice.
Yep.
Yeah, well, I'm going to move on to 3D in a moment. Okay.
So I think the 18 was a very was the right choice. Thank you, Kevin. I think that if you used that 25, it would just have covered an unnecessary large area of the atrial septum.
Okay, now I go for the bubble testing. That looks all normal. There are a few bubbles passing, but that's quite normal at this moment. So
you could do that. You could do that with 3D, and you'll see where the bubbles are coming from. I think Nina showed very nicely this morning that the.
So let's have a We are preparing a 3D.
Very good. Do you want to do some bubble now?
Yeah, we are coming with the bubbles.
Ready, almost ready. One few seconds. That's the most funny part, preparing bubbles. Now you see bubbles coming. Not very much.
There's obviously no shunt at all.
Yeah. Well, I think that's an excellent result.
Okay, now that's better now. Okay.
And you can see there was absolutely no shunt, not a single bubble passing.
Yeah, that's a very nice profile, Carmelo. Very, very good demonstration. Okay. That was an excellent result. I'll see whether there are any questions from the floor or the panel. Are there any questions? No? I think very, very, very good results. Thank you very much.
Big applause to Eman.
Your colleague.
Thank you.
Yeah,
Thank you.
See you.
Congratulations. and we wish her well.